academic coordinator, Dr. Thirumurugan, to going this program very well. Thank you very much.
Thank you, sir. Now I request our scientific advisor, Professor Singaroda, sir, to say a few words and then start the program.
Thank you, Dr. Thiru. Our visionary president, Dr. Rajendran, who has made actually this program when he was in various capacity as a treasurer, as a secretary, along with Thiru and others, it is going very well. And I'm happy to have our own youngest student of all learners, teachers of teachers. He always considered that he is the youngest student, Professor Srinivasan sir here. I'm happy that my good friend Santosh has been here, whom we know that more than a decade, and he is a man who will be always very quiet, but he is a very knowledgeable. I think I should thank Kritika for selecting wonderful people, and of course the mentor, Professor Sridevi Narayan Madam. We do not talk much about her, and Jnana Samandam, my good friend, and he will do extremely very well, and the participants of the both postgraduates, and of course our past EB member Dr. MSV is here, and many more, Rajkumar, Dashayani, and of course the team 2025 under the leadership of Dr. Rajendran, who is doing extremely well. And as our president told, it is spreading all over India, so that definitely it will help our students. When I passed this flyer to my group of other states, immediately they wanted to, sir, can we join? Can we, sir? You can all join, I told, and some of them from other states, they have joined. I'm happy that Lalita Janira Madam also joined. With this, without wasting much time, I hand over to Thiru to continue the proceeding with Kritika and Sridevi. Thank you. Thank you. Once again, thank our president for giving me this opportunity as a scientific advisor. Thank you, sir. Thank you.
Thank you very much, sir. Without wasting much time, I now request Dr. Kritika to take over the stage and then conduct the program.
Respected President, sir, Academic Advisor, sir, Professor Srinivasan, sir, Honorable Members of IAP TNSE, Thirumurugan, sir, today's faculties, mentor and learners, happy and good evening to all of you. Albert Einstein once said that education is not just the learning of facts, but the training of the mind to think. But unfortunately, as students, the place where we think more will be the exam hall. It is not because of the ignorance, but because of the anxiety and fear we face during the exams. So to overcome this anxiety and fear, IAP TNSE is purposefully organizing this PG class, which demonstrate to you how your university exams look like. So I want all the PGs to kindly utilize this program. And the topic for this month is cardiology. Heart is always a fascinating organ, and it gives you a life lesson. Even if the environment gives you an impure thing, heart receives the deoxygenated blood, but it always gives the output as the oxygenated blood. But the two key important persons who make it possible will be the gateway to the good blood, that is a pulmonary valve, and two great valves, the interatrial septum and the interventricular septum. So what will happen if the valve is inefficient and if the valves get breached? To discuss the situation, we have with us an eminent teacher, a great scholar, an astute clinician, a wonderful author of many books, Professor Dr. Santosh Kumar sir, who is currently holding the position of Professor and Head of Pediatrics and Medical Superintendent of Azizia Medical College, Kerala. And also he is a former HOD and Professor of Pediatrics from Trivandrum Medical College. And another experienced clinician and phenomenal teacher, Professor Dr. Jnana Samandam sir, Professor of Pediatric Cardiology from ICH and HC. The learners are Dr. Ramya, Dr. Vignesh, and Dr. Gomati under the able mentorship of dear Professor Dr. Sridevi ma'am. So over to Ramya for presentation. We will be having the case discussion for the next 1 hour, followed by 20 to 30 minute short scholarly lecture by Dr. Santosh Kumar sir. Over to Ramya. Dr. Ramya,
thank
please
you very much.
start your...
You can start them.
Good evening, ma'am. Good evening, sir. Pranav Sai, a 6-year-old male child, firstborn of non-consanguineous marriage, informant being mother, who speaks Tamil, whose reliability is fair, presented with chief complaints of bluish discoloration of lips and fingers noted since 2 years of age, difficulty in breathing during activities. Now child admitted electively for surgery. Presenting complaints, child was apparently normal.
Before proceeding, can you give your final diagnosis, please?
Tetralogy of Fallus.
Tetralogy. With any complication or without any complication?
Without any complications.
Okay, please proceed.
Presenting illness, child was apparently normal till 2 years of age according to the mother. Around 2 years of age, mother noticed bluish discoloration of lips and fingers, no history of intermittent intensification of cyanosis, no history of any squatting episodes, breathlessness on exertion since 2 years of age, which was insidious in onset, which was grade 2 as per NIHA classification, which is non-progressive, aggravated by exertions like climbing stairs, running, which is relieved by rest. No history of orthopnea or paroxysmal nocturnal dyspnea, no history of chest pain, palpitation or syncope. For the above complaints, mother did not seek any medical attention. On October 2024, child had fever and cough cold for 3 days, for which child was admitted in a private hospital, where child was evaluated and found to have heart disease and referred to ICH. There is no history of failure to thrive or growth retardation. No history of headache, seizure, altered sensorium, focal neurological deficit. No history of fever with chills and rigors, rash or hematuria. History of dental caries present for which extraction done. No history of bleeding gums or epistaxis. No history of hemoptysis. Now child was evaluated in ICH ward, started on an oral tablet which was given twice a day, probably propranolol. History of tooth extraction done. Antenatal history. Mother married at 22 years of age. Maternal age at conception 23. Spontaneous conception, which was booked and immunized at RSRM. Mother had 6 antenatal visits. No history of hypertension, diabetes, or hypothyroidism. No history of any cardiac illness in the mother. No history of fever with rash or lymphadenopathy. No history of any drug intake. No history of radiation exposure. Iron folic acid tablets taken. 4 antenatal scans were done, which were said to be normal. Natal history. The delivery, it's a post-dated spontaneous onset of labor, delivered via emergency lower segment cesarean section. Due to non-progression of labor, birth weight was 2.5 kg. Child cried immediately after birth. Breastfed within 1 hour of birth. No history of cyanosis or breathlessness at birth. No history of any NICU admissions. Developmental history. Head control attained by 5 months
is it
of
normal
age.
or abnormal?
Sir,
Development, is it normal or abnormal?
there is a mild motor delay. Now child
Motor.
catch up. Sir.
Oh, can skip.
Did I continue developmental history or skip?
No, you can
sir?
skip that. The summary is that there was an initial delay in gross motor, and now he has caught up with age appropriate. Okay.
Yes,
am I right?
yes, sir.
Okay.
Yes, sir.
You can skip.
Yes, sir. Immunization history. Child immunized up to 1.5 years of age according to universal immunization schedule in a government hospital. No additional vaccines given. BCG scar present. Diet history. For expected of 1400 kilocalories, child is taking 1150 kilocalories with 350 kilocalorie deficit. For expected 30 gram of protein, child is taking 24 gram protein with a deficit of 6 gram. Family history, child is a firstborn of non-consanguineous marriage. There is no history of any heart disease or abortions in the family. Socioeconomic status, father studied up to 12th standard, he's a fisherman. Mother studied up to 10th standard, she's a homemaker.
Can skip that also. Yeah.
Okay, sir. Summary.
Okay.
It's a 6-year-old male child, firstborn of non-consanguineous marriage with cyanosis noted since 2 years of age. Dyspnea of grade 2 since 2 years of age, with no history suggestive of cyanotic spells or squatting episodes, without recurrent respiratory tract infection, without any complication, with no history suggestive of a cardiac failure or infective endocarditis. Probably it's a case of congenital cyanotic heart disease with reduced pulmonary blood flow, possibly top physiology. I would like to proceed with my examination, sir.
Okay, before that, you said no drug intake during, no significant drug intake. What drug do you have in your mind?
Sir, anti-epileptics like valproate, phenytoin, carbamazepine can cause tetralogy of Fallot. Other like warfarin can cause cardiac defects. Sir?
Yes, warfarin. Yes. You said
Yes, sir.
NYHI grade 2, no? What do you mean by that?
Yes, sir. New York Heart Association classification
Yes.
of breathlessness.
2
sir.
means? 2 means?
Sir, 2 means child having breathlessness while exertion, sir. While climbing stairs, while walking long
Okay,
distance.
fine.
What are the parameters you grade by NYHA? Sir, can I?
Yes, sure.
What are the parameters you grade by NYHA?
So grade 1.
What are the parameters? Like shortness of breath you're grading, dyspnea you're grading. Any
yes,
other symptomatology you grade with your NYHA?
breathlessness and heart failure.
Not heart failure. You also grade the same classification is also used for chest pain, palpitation, and fatigability.
Yes, sir.
So, what is class 1 or what is class 2?
Class 1, breathlessness with strenuous physical activities, sir. Class 2 with normal physical activity. Class 3 is activities of daily living.
No. This is not the classification. What you say is the Ross classification. NYHA is different. Just go through that. Class 1 is patient with cardiac illness without any symptoms.
Yes, sir.
So you always get confused with the first stage and the other classifications. This is a patient with maybe he may have a mild AS, but not have any symptoms. The symptoms are 4 grade: chest pain, palpitation, fatigability, and shortness of breath.
Okay, sir.
Okay, just go read up about NYHA.
Yes, sir.
Okay.
And you said some tooth extraction. Ramya, am I audible?
Please, Sindhu madam. Okay. Proceed, sir.
Okay, Ramya, audible?
Yes, sir.
Okay, you said about some tooth extraction, no?
Yes,
so
sir.
before tooth extraction, suppose the child comes to you, what advice are you going to give regarding prophylaxis?
So maintain oral hygiene, sir.
No, prophylaxis. The dental surgeon is referring the case to you.
So prophylaxis, if before doing any extraction, I will prescribe amoxicillin 50 mg per kg half an hour before the procedure, sir, to prevent endocarditis, sir.
Okay. Half an hour, I do not know. Maybe cardiologist will explain. Usually, it is 1 hour.
It's taken orally 1 hour before the procedure.
Okay, you can proceed with it.
If it's a urinary tract procedure, any other thing you add or
No need for that, sir. Only for oral procedures or upper respiratory procedures.
the choice of antibiotic is different when you have a infected urinary procedure. Okay, you also added aminoglycoside.
Cefixime. Yes, sir.
Cefixime, not
yes,
aminoglycoside. And you told about bluish discoloration since 2 years of age. What is the inference you get from this complaint?
Delayed onset of cyanosis.
When does it typically, you have told the diagnosis already?
Yes, sir. Yes, sir.
With the onset of cyanosis, do you come to some conclusion regarding the condition?
Normally, TOF child will have cyanosis around 4 to 6 months of age, sir.
Why is it delayed?
Maybe due to right ventricular outflow obstruction, maybe less severe, or a child having collateral, sir, or PDA.
So what happens when you have collaterals?
When we have collaterals, this a child can have congestive cardiac failure symptoms, sir.
Okay. How is it related to cyanosis here?
So, due to collaterals, the deoxygenated blood will be the child will get better oxygenation will be there, sir. So cyanosis will be delayed, sir.
No, basically the answer we expect is what was the with collaterals you have decreasing cyanosis.
Yes, sir.
Okay. The
Yes,
main
sir.
reasons would be with age, you have increasing RVOT obstruction, you have increasing activity, and the during in neonatal period, the presence of fetal hemoglobin is going to, what does it do?
So, around 6 months of age, fetal hemoglobin will have high affinity for oxygen, sir.
So what
Around 6 months of
happens?
age.
What
Sir?
happens when you have a high affinity?
The cyanosis will get, reduced hemoglobin will be low, sir. In adult hemoglobin, the reduced hemoglobin will be high, sir.
Okay. When you have a high oxygenated hemoglobin, what happens?
Cyanosis won't be occurred, sir.
Yeah, it is delayed.
Yes,
And
sir.
with the age, what happens to the collaterals?
The collaterals will increase over the age, sir.
Okay, okay,
Yes, sir.
okay. So what is your inference when you have cyanosis at 2 years of age?
Child may have collaterals, sir.
So what are the conditions wherein you have cyanosis at birth, a little delay?
At birth, transposition of great vessels, TAPVC, pulmonary atresia, tricuspid atresia, truncus arteriosus can have cyanosis at birth, sir.
At birth. If it's delayed by
Yes,
few
sir.
months,
No,
it's going
in
to physiology.
tetralogy itself, suppose it is cyanotic at birth, then what will you think of?
Severe pulmonary stenosis
Yes,
may
yes.
get associated
Like
or
pulmonary
pulmonary
atresia.
atresia.
So what
If
sir
it
is
is
asking
if it is
is,
pulmonary
when do you
atresia, do
have-
you really expect PDA to be helping, or you do not expect PDA to be helping? Do you
Yes,
expect
sir.
PDA to be patent
Yes,
and
yes,
helping
sir.
in yes or no?
Yes, sir.
Why?
It's a duct dependent. It's a duct dependent circulation, sir. So we have to start the child on prostaglandin.
No, actually, when there is pulmonary atresia, see why the ductus is open in newborn period, because your right ventricle is pumping to the pulmonary circulation, and that is not needed, so that through the patent ductus or the ductus arteriosus comes to the aorta and goes down. But when
Yes,
there is
sir.
pulmonary atresia, hardly any blood is going to pulmonary circulation. So there is no need for sending of blood from pulmonary circulation to systemic circulation. So the ductus will be rudimentary. So in a pulmonary atresia, you really do not expect a big PDA supporting the circulation. It will be collateral. Okay.
Okay, sir.
PDA, it's a duct dependent right-sided lesion, pulmonary atresia.
Yes, sir.
Oh, okay. That's why you use prostaglandin to open the.
Prostaglandin.
What happens is the lung only supply is through the supply from the PDA.
Yes, sir.
Okay, okay, fine.
Shall I proceed with the examination?
Yes,
sir?
please. Yes.
Yes. Examination. Child is conscious, oriented, afebrile, comfortable at rest, sitting over the bed. Left microphthalmia present, conjunctival suffusion present, ears normal, central cyanosis present, pan-digital clubbing of grade 2 present,
Do you have
No
the clinical
icterus.
photo? Can you put the clinical photo when you give the physical examination?
Yes.
Yeah. Yeah, you can talk now.
No icterus, clubbing or sorry, sir. No icterus or lymphadenopathy present. Skin normal, no rash, palms and soles normal.
What happens to the left eye?
So left eye child having microphthalmia, sir.
Right eye is normal.
Right
Any
eye is normal, sir.
any loss at ears?
No, sir.
Does when you extend from the lateral canthus, where is the ear placed?
Sir, 1/3 of the ear above the line, sir.
Here? It's low set.
Normal.
Okay, no, it's low set.
Yes.
Okay. Any
Yes.
other dysmorphic facies?
Upturned lip slip is there, sir. Inverted upturned lip.
So
lips
what
is
is
there.
the specific syndrome you look for in a TOF or a pulmonary atresia?
Sir, Dijard syndrome, sir.
Okay, what are the features you look?
Sir, Dijard syndrome, child have cleft lip, cleft palate will be there. Catch 22, sir. Cleft lip, cleft palate, abnormal faces, cardiac defects, thymus hypoplasia will be there, sir. Hypocalcemia will be there, sir.
Okay. What is the abnormal faces you see here?
So hypertelorism, epicanthal folds will be there, sir. Cleft lip, cleft palate will be there. Micrognathia will be there, sir.
Okay, you look specifically for features of catch-22. Why?
Yes. So TOF is most commonly associated with the Dijard syndrome, sir.
That is the commonest syndrome which is associated with TOF. Okay,
Yes,
nearly
sir.
15 to 20% is associated. Whereas if it's
Yes, sir.
going to be pulmonary atresia, TOF with pulmonary atresia, this percentage is going to increase to 40 to 45%.
40%.
So every
Yes, sir.
second child is going to be a catch-22 when you have a TOF
Yes.
with pulmonary atresia.
Yes, sir.
So this is the commonest syndrome which is associated with your
TOF,
TOF
sir.
with pulmonary atresia. Okay.
Yes, sir.
So this is a pan-digital clubbing. Okay.
Yes, sir.
Okay. Why pan-digital? If it's lower limb alone,
Lower limb balloon,
which will cause lower limb alone? Differential clubbing.
differential clubbing will be there in if the child is having
Whatever
PDA
condition.
with reversal.
Yeah. PDA with
Reversal, sir.
reversal. Yeah. Differential cyanosis and differential clubbing goes together.
Yes, sir.
Okay. So you want to ask some?
No, you proceed.
Yes. Vitals, temperature 37.4 degrees Celsius, measured at right axilla. Pulse rate was 105 per minute, regular in rhythm, normal in volume, no specific character, no radial or radiofemoral delay. Pulses equally felt in all peripheral pulse arteries. Respiratory rate was 22 per minute, normal work of breathing. Abdominal thoracic type of breathing. BP 164, which is 50 to 90th percentile, measured in right upper long in lying. Saturation, right upper limb 88, 86 percentage, lower limb 86 or 87 percentage in right and left respectively. Anthropometry, height 105 centimeter, which is less than third centile. A child comes under stunting. Weight 15.5 kg, third to 10th centile, which is normal. BMI 14.6, 25 to 50th centile, which is normal. Examination of the cardiovascular system.
What about you're talking about a congenital heart disease with associated syndromes? Any other
Yes.
anthropometry you are missing?
Arm span, sir.
Arm span, yeah. Upper
Um,
segment, lower segment ratios,
Yes.
upper segment, lower segment ratios.
Yes.
Also, your head circumference should be mentioned.
Yes, sir.
Okay, okay. Please carry on.
Examination of the cardiovascular system. Inspection. Trachea appears to be in midline. Size and shape of the chest normal. Precardial bulge present. No visible pulsations. Apical impulse not seen. No scar, sinuses or dilated veins. No epigastric pulsations. Palpation. Tracheal position confirmed to be in midline. Apical impulse felt in left to fifth intercostal space 1 centimeter. Medial to midclavicular line, which is not associated with any thrill. No palpable heart sound, no parasternal heave. Percussion, left
Yes,
heart border
is the
corresponds.
apex normal?
Sir?
Is the apex normal?
Yes, sir.
Palpation.
Yes, sir.
Okay. Is it RV apex, LV apex?
It is RV apex, sir.
Why?
Which is tapping type of impulse, sir.
Why
You
does
cannot,
it
don't
say
commit
tapping?
tapping and all. It is typically only in mitral stenosis you get tapping.
Okay, sir.
So how do you differentiate left LV apex and RV apex?
Sir, RV apex will be felt a little more laterally, sir.
Okay, RV will be more lateral, LV will be
Medial, sir.
by
Comparative
medial.
for
Down
that.
and out. This is only out.
Yes, sir.
Huh? Then what
Yes.
else? RV is in continuation with your parasternal impulse.
Yes,
Whereas
sir.
LV has a zone of medial retraction, meaning you have a RV impulse, then a zone of medial retraction to the medial to the LV apex.
Okay, sir.
Okay,
Okay, sir.
fine.
Percussion,
Any
left
other
heart.
RV association which is not associated with LV?
Sir?
Anything which is any other finding which is associated with the RV apex but not associated with the LV apex? What happens to epigastric?
Efficacy
Where is
pulsation
it?
will be there, sir.
So what does it mean?
RV.
It is associated
No.
with RVH.
Yes, sir.
Okay, LV won't be associated with the.
Efficacy pulsation, sir.
Okay, okay. Okay, please proceed.
Percussion, left heart border corresponds to apex, right heart border corresponds to right sternal border. Auscultation, in pulmonary area, first heart sound heard, normal, loud, single, second heart sound
Do you
heard.
really start with pulmonary area?
No, sir. We have to start with the
So
mitral
generally
area.
go with systematically. And in your inspection, bulging of precordium is not very much in tune with your job.
Yes,
Is there
sir.
a bulging? And we usually do not expect. Okay.
And always you're dealing with the congenital heart disease. So you always mention whether the first thing you mention is whether the apical impulse is on the right or left, because you could be dealing with the dextrocardia.
Yes.
Any
Okay.
complex congenital heart disease may have a malposition also.
Yes, sir.
Itis inversus, evocardia.
Okay, sir.
Proceed,
Shall I
proceed.
proceed, sir? Yes. Mitral area, first and second heart sound heard. Tricuspid area, first and second heart sound heard. Aortic area, first and second heart sound heard. In pulmonary area, first heart sound heard normal. Loud, single, second heart sound heard. ejection systolic murmur of grade 3 in left third intercostal space. There is no thrill, best heard with diaphragm of the stethoscope. No other murmur heard over interscapular or infrascapular area or any other area, sir.
Your second sound, single and loud. What is the reason?
Sir, in TOF, iota will be more anterior, sir. It is close to the chest wall, so A2 will be heard loudly.
Why is it anterior? Why is it anterior?
Sir, in embryology, due to conus septum will be malaligned, sir. So iota will become a spiral septum due to irregular abnormal rotation of a spiral septum.
Actually, you do not need all those explanation. When the pulmonary is so small, and the aorta in TOF is actually dilated. So
yes,
naturally the sound will conduct better because the pulmonary is not there in front. It is very, very small.
okay,
That
sir.
could be the reason. And the second thing is your murmur in the third intercostal space. What is the reason for that? Rather than the pulmonary area?
It's normally infundibular stenosis.
Okay, good. Yeah. It may not, I mean, if it is valvular, of course, it should be in the pulmonary area. But if it is infundibular, it can be down.
Yes.
Right. You're correct.
No other murmur heard over in interscapular or infrascapular or any other areas.
What murmur are you looking for?
So I'm looking for murmurs of collaterals, sir.
Okay, collateral means what collateral?
So iotopulmonary collaterals, mainly bronchopulmonary.
Iotopulmonary, is it very common? What is the commonest collateral?
Bronchopulmonary.
Iotopulmonary is not very common. I mean, from descending not very common. Even from intercostal or mammary, that is also not very common.
Yes.
Okay. Go on.
So I got disconnected. Sorry for that because of the signal issue.
Examination of. Sir?
Am I audible? I got disconnected.
Yes, audible.
Yeah.
Yes, sir.
Yes, sir, you're audible,
I was
sir.
telling you about the site of murmur. So if it's going to be second intercostal space on the left, it's going to be pulmonary area. Below that, if it's going to be third, it's going to be
infundibular stenosis.
Second area, it's going to be supravalvular.
Yes.
In fact, this goes by a sign called Oram's sign. Each space is going to indicate where the obstruction is.
Yes, sir.
Okay.
Examination of the other system. Respiratory bilateral air entry present, which is equal. Normal vesicular breath sounds heard. There is no added sounds. Abdomen soft, non-distended, non-tender, no organomegaly. Liver span 6 cm. Liver present on the right hypochondrium.
Again,
tympanic
this has to be stressed. Abdomen, whenever you say it's going to be a congenital heart disease, so you are expecting situs, abnormal situs also. You always say liver's on the right side and the tympanic resonance of the stomach is on the left side. So you always concentrate on the situs when you are going to approach a congenital heart.
Okay, sir.
And why spleen is it important?
Yes, sir.
Why?
In situs inversus can be associated with asplenia or polysplenia. Maybe
that is okay. That is also a thing to be discussed. Any other thing which is very important? Spleen.
Infective endocarditis. Splenomegaly.
Infective endocarditis, and also in your situs ambiguous. Spleen have a spleen.
Spleen can be on the right side.
Yeah, liver can be bilateral. Okay.
Yes.
Okay.
Central nervous system tone is normal. There is no focal neurological deficit. Left microphthalmia present. Left eye isotrophia present. Visual acuity 6/6 on both eyes. Summary. A 6-year-old male child, firstborn of non-consanguineous marriage with bluish discoloration of lips and fingers, exertion dyspnea since 2 years of age, no history suggestive of congestive cardiac failure or infective endocarditis. No, there is no significant birth history or family history. Examination revealed central cyanosis, pan-digital clubbing, conjunctival suffusion, left microphthalmia with normal vitals. Cardiovascular examination revealed a single loud S2, ejection systolic murmur at the third intercostal space on left side. My diagnosis, congenital cyanotic heart disease with decreased pulmonary blood flow, most probably tau physiology with no signs of congestive cardiac failure, infective endocarditis in sinus rhythm without any complication. Child is stunted, normal development.
Okay.
There is no collaterals of PDA.
That's in examination, there is no murmur for collaterals at PDA.
So
Sir.
there is without any collateral, the child had probably no significant cyanosis up to about 2 years of age. Is it possible
No,
that the child started as a pink fallow and now became classic fallow?
Yes, sir, possible due to pulmonary valve infundibulous
No.
stenosis.
Before
in
saying
vitro.
possible, then you should have some evidence of increased flow during your infancy. Was there any hospital admission for respiratory infection?
No, sir, there is no admission before that, sir.
Then you cannot really say it is.
Then can you explain this late onset cyanosis?
It's a little late because usually by 1 year, generally,
Yes.
between by 6 months, most of them will be cyanosed. But
Yes,
by
sir.
1 year, we expect. But this cyanosis was noted only by 2 years. Maybe the parents missed this one possibility.
Yes, sir.
But apart
Yes,
from
sir.
that,
Mother may miss the finals. The mother was not sure. She's saying mostly after 2 years only I noticed only. She said, sir.
So any other cause for late onset cyanosis?
So Eisenmenger syndrome can present after 2 years.
So how does it
In
present
BST.
during infancy?
Sir?
During infancy, what is the Eisenmenger? How does it present? A child with Eisenmenger.
PDA child.
That's what. Any left to right shunt at the ventricular level, VST, atrial level, AST or a PDA, that is at the great artery level, PDA or a AP window can have Eisenmenger. How does it present? So early infancy, during infancy, the child is going to present with features of congestive cardiac
failure.
Then
With improved
apparent
child
improvement.
with improved symptoms.
Clinically, the child improves. Then your onset of
Cyanosis develops.
cyanosis develops. So when does it occur?
Around 2 years of age. Sir.
So the onset of Eisenmengerization is by 2 years. But when does a AST present? When does a VST present? When does a PDA present?
So PDA present in new hemodynamically significant PDA can present in newborns. Sir.
No, doctor. Eisenmenger. PDA Eisenmenger. When does it present to you?
Around 6 to 7 months of age.
Eisenmengers are generally quite delayed, not really during childhood, except when you have a chromosomal anomaly. Suppose you are having a Down syndrome, then it could be different. But in a child having no dysmorphism, Eisenmenger at 2, 6 months, 1 year, etc. is very, very important. It's a very dangerous diagnosis to put forward in there.
So the routine teaching would be PDA will be early on, even during the first decade. Second decade will be a VST, then AST. And AP window still earlier. It's not late. Earlier. As sir said, you can have Eisenmenger in a Down's child or in a child born in a high altitude. These are going to cause your pulmonary vascular resistance to develop early on.
Okay, sir.
Okay.
Okay, go on to investigation.
Yes, sir. Complete blood count, sir. Hemoglobin is 19.2 gram per deciliter. Hematocrit was 63.
With this
Other
PCV,
parameters.
would you like to intervene or leave alone? PCV
More
of
than
63.
65, we have to intervene, sir. Or child with symptoms of
Without symptom at 63, do you intervene?
no, sir. After 65, we have to intervene, sir.
Even at 65,
Symptom.
without
Our
symptom,
child having
you may even still wait. But 63,
no, sir.
possibly, you will not.
Yes.
So what is the rough hemoglobin? Do you, with these indices, do you have some clues whether the child is anemic or not anemic?
So MCV we have to see, sir.
Okay. Anything which you have missed in this, which is going to tell you it's going to be iron deficient.
Peripheral smear, peripheral smear, ferritin, RBC indices.
What RBC indices is going to specifically tell you it's iron deficient.
So MCV, sir, mean corpuscular volume.
What is it going to be?
So mean corpuscular volume will be low, sir.
Okay.
Hypochromic, microcytic hypochromic RBCs will be there, sir, in iron deficiency.
Any other feature?
RDW.
What is RDW? That is going to be more specific for your iron deficient.
Iron deficiency, sir.
If it's going
RDW
to
will
be
be
high,
more,
it's
sir.
going to be iron deficient.
Yes, sir.
So why RDW is not mentioned in this? So that has to be specifically seen.
Yes, sir.
Otherwise, can you have a clue from this indices? One is your MCV, one is your MCH and MCHC.
It's
Okay. Any other clue from your hemoglobin?
if the hemoglobin is less than 14 gram per deciliter, we can consider child having anemia, sir.
So a normal hemoglobin for us will be anemia for a cyanotic heart.
Yes, sir.
Okay.
Yes, sir.
Roughly, we have a formula 38 minus saturation. Anything you know?
No, sir.
Okay, leave it. It's not a standard formula. Proceed.
X-ray, X-ray showing upturned apex with pulmonary oligemia.
That's all. You read this X-ray.
Sir.
You read this X-ray.
It's a chest X-ray.
Stepwise, what all you see?
It's a normal sized heart, sir.
It's a X-ray chest, APPA.
So it's a chest X-ray, PA view, AP view.
Why did you say PA?
So it's an AP view, sir. Sorry, sir.
Okay. In pediatric population, we usually take a AP view. Okay, even in bed X-rays, it's going to be AP only, not PA.
Yes.
Never PA.
Yes.
Okay. Unless it's a grown-up child, you take specifically PA.
Yes,
Then
the lung fields are clear, sir.
again, rotation, penetration. These are routine things. You say at least it's normally penetrated. It's centered well, not rotated. Then go from heart to peripheries or peripheries to heart. You're starting with your heart, right?
Yes, sir.
Okay.
It's a normal sized heart.
By normal sized? Did you see the CTR?
No, sir.
Okay. Then How is the
upturned
apex?
upwards.
It's a LV apex or RV apex?
It's an RV apex, sir. It's upturned and it's placed laterally.
Okay. Anything else?
Pulmonary oligemia is there, sir.
No, again, your heart, anything else on the right side?
Right
Likely a RA
atrial.
enlargement.
Yes, sir.
Likely a RA enlargement.
Yes.
Yeah, you keep talking. You keep talking. Anything
Yes.
about the arch-sidedness?
So left arch, sir.
Why left arch? Can you enlarge the image?
Sorry, sir, there are other couple of pages as well. We can call them also.
Pardon, sir? Pardon?
There are a couple of other PGs also are in the program. Who are supposed to be part of the program. So we can involve them also. Apart from Dr. Rabia.
So apart from the presenter, others will answer. So I'm not getting it.
So we have 3 learners today, sir. Ramya, Vignesh, and Gomati. They can also answer in the sir is
Yeah,
telling,
yeah,
sir.
please. Others also participate. Vignesh,
Sir, yes, sir. Arch of aorta is on the left side, sir.
why?
Trachea is slightly shifted to the right side. So probably it's a left side.
You don't go by the shift of the trachea. You see for the indentation,
the aortic knuckle. For the
indentation of the trachea.
yes, sir.
Not very obviously seen. Okay. Okay. Then
Device on the right
other
side.
chambers,
So
other chambers we are not able
Sir?
to. Other chambers we are not able to comment. Probably RVH because of the RV apex. And
Yes,
RA
sir.
appears prominent.
RA is slightly prominent. Sir.
Prominent. And what about
Yes,
the
sir.
lung field?
Lung fields here lung fields appear normal.
Can you diagnose any syndrome with this X-ray?
Sir, if left lung is hypoplastic,
No. What happens to the thymus, discharge?
the thymus will be absent, sir. Hypoplastic. Sir.
Okay. Any genetic syndrome, other genetic syndrome, which may be associated with TOF?
In allergic syndrome, butterfly
No,
vertebra
that doesn't have any radiology. Any Downs features? What does Downs cause in X-ray chest? What does it have present in X-ray chest? So that the 12th rib will be absent. Okay. Downs typically. Okay. Then what about the lung markings? Tell me about the vascularity.
Vascularity appears normal.
So does it correlate with your clinical diagnosis TOF with no collaterals?
No, sir.
No, sir.
So what could be the other cause? So probably associated collaterals are there because of the
Yes.
prominent lung markings. I mean bronchovascular
Yes.
markings.
Yes.
It's not decrease pulmonary blood flow, at least in this X-ray.
Yes.
Okay. Because it's well seen even in the outer 1/3 of the lung field.
Yes.
Okay. Okay. Proceed. Next investigation. So what is the? You
ECG.
can read the X-ray. I mean ECG.
It's
So 12 lead ECG showing a normal
Always,
sinus rhythm.
even like in a X-ray, you talk about
Oh.
penetration, centering. Here, what do you
Yes.
talk about in a ECG?
Sir, we have to see for the rate, sir.
Normal
25
standardization,
in normal standardization,
normal speed, 25 mm per second.
25 mm per second, sir.
Okay, then go on to your proper reading. Okay,
Okay.
okay.
It's a 12 lead ECG with a normal standardization showing a normal sinus rhythm with pulse rate around,
What is
heart
a
rate around
normal
80 per
sinus
minute.
rhythm? What is a normal sinus rhythm? It's a sinus rhythm.
Sir,
That's all. There's no abnormal sinus rhythm. It's a sinus
sir,
or a
for
non-sinus
sinus
rhythm.
rhythm, sir, for sinus rhythm,
No,
speed,
you don't put the term as normal sinus rhythm. It's a sinus rhythm
speed
or
will be
non-sinus.
normal. Each P is followed by a QRS complex, sir.
Okay, fine. You proceed.
Okay, sir.
Thing I wanted to tell is no normal sinus rhythm. It's a
Okay,
sinus
okay.
rhythm. Okay,
Sinus
okay.
rhythm, rate is around 80 per minute, showing a extreme axis deviation.
Extreme?
V1 lead shows tall R waves.
You are talking about axis.
Yes, sir.
Yeah, what axis?
Right, right axis deviations.
Okay. Okay, it's around plus 150. Okay.
Yes.
Because ABR is positive and V2 is negative.
Yes.
So around
Yes, sir.
150. Okay.
V1 lead showing a tall R wave with a minimal T wave inversion is also seen in V1, sir.
In ECG, you know the clinical diagnosis. You will
sir.
be confirming the diagnosis with your ECG features. You don't read
Yes, sir.
ECG in isolation. You always go have your diagnosis in your back of mind and try to pinpoint the features in the ECG. You put it as TOF now. What are
Yes,
the
sir.
features of TOF here?
So right
Any
axis
typical
deviation
feature of a TOF? Any
features
atypical
will be
feature
there.
of a TOF?
Okay.
What is typical
features
here?
of- Sir?
What is typical of a TOF here?
Sir,
In ECG?
RVH pattern will be
That
there,
can
sir.
occur even in DORB.
Sir?
That can occur in other cyanotic heart diseases, TOF-like physiology, like DORB with PS, single ventricle of
Yes, sir.
RV
Other than that,
morphology.
monophasic R wave in V1, while in other leads, R wave will be normal, sir.
No, the typical feature will be
Sudden
rapid
transition transition of R wave to S wave in V2 will be occurs, sir.
V2, ideally
Yes.
V2. Here the transition occurs at V3.
V3, sir. Here it is occurring at V3, sir.
At V3.
Yes.
Okay.
Yes, sir.
Okay. Probably because of malposition. I mean, you're positioning the lead a little below, something of that sort.
Oh.
Okay. Any other feature? Which doesn't occur in a TOF. A little atypical will be a extreme right axis deviation. Axis of 150 will favor more of DORB than TOF. TOF will be around 120 to 150. Okay, proceed.
Echocardiography, situs solitus, levocardia, pulmonary
You're
atresia,
showing the
large
investigations, blood investigations. Okay, yeah. On the right, okay, fine. Yeah.
pulmonary atresia, large inlet muscular VSD, pulmonary artery confluence is posterior to aortic outlet, intact atrial septum, RVOT in blindly, small PDA supplying PA confluence, fair size PA confluence, Left pulmonary artery 19 mm, not well profiled. Right pulmonary artery 10 mm, normal biventricular function.
Okay. So this is correlating with your X-ray finding of pulmonary atresia with, when this is not correlating actually. You should
CTP
have
is there.
collaterals here. You should have collaterals here.
It's present in
Or a
CTP.
PDA should be large to have a good pulmonary vascularity in the X-ray.
Yes, sir.
The pulmonary atresia
Go to
without
other
collateral murmur is clinically undiagnosed.
And also when you have a ESM in the pulmonary area, it rules out a pulmonary atresia.
Yes.
So it doesn't favor a pulmonary atresia when you have a ESM. Either your clinical interpretation is wrong or the diagnosis of pulmonary atresia in the echo is wrong. Okay, we'll go on to other investigations. Not clear, doctor. Not at all clear.
You can just tell us
You please read
the
it out.
inference.
Yes, sir.
Angiogram. CT angiogram. What was the
Yeah,
inference?
please read it out. We are not able to read this. Even you are not able to read this.
Can I read, sir?
Yes,
Can I
sir.
read?
Yeah, yeah.
Symbiotic
CT
ventricular
pulmonary.
septal defect. C.
So I'll read.
Overriding of. Can you read, ma?
Yes, ma'am. Yes, ma'am.
Yes. Yes. ma'am.
Subaortic ventricular septal defect seen, overriding of aorta noted. Aorta appears dilated. Ascending aorta measures 2.7 centimeters. Right carotid artery arises from arch of aorta to the left trachea and crosses anterior to trachea in suprasternal notch. Upper right artery noted. A large
I think your connection is disturbed, Ramya.
Doctor, your signal is. What about other PGs? Their connection is okay?
is.
Vignesh?
They're all on.
one
They're all
more.
connected
Can you
via
hear
the
me
same
now?
device. I think. Yes. 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 Yes, ma. Yes, ma.
Yes.
You
Can I
start
read
from
from
that
the
large
beginning?
artery. Yes. You read from your large artery measuring.
Okay, ma'am. A large artery measuring 1.2 centimeter noted arising from undersurface of aorta and supplies the left main pulmonary artery through restrictive opening. Left pulmonary artery 3 mm, right pulmonary artery 1.2 centimeter, distal main pulmonary artery is 1.5 centimeter, proximal main pulmonary artery appears atretic. Multiple small collateral vessels noted arising from aorta and its branches entering the bilateral hilum. Veno-arterial concordance, atrioventricular concordance is there, interatrial septum is intact, bilateral lung parenchyma, no significant abnormality.
So probably this is only pulmonary atresia with many AP collaterals, right?
Yes, sir. Yes, sir.
So this is correlating with your clinical features since its cyanosis is presenting late.
Yes,
but
sir.
you shouldn't have a ESM in the pulmonary area.
Okay.
The pulmonary atresia. So you need to go and recheck your clinical findings only. And probably we are missing collateral murmur also, continuous murmur in the axilla over the back. So you carefully auscultate for murmurs over the back, specifically in the axilla.
Okay.
40%.
I'll reconfirm, sir.
Okay, okay. Okay, tell me how do you go about?
Sir, a 6-year-old child.
No, you can just skip all those things. How do you treat?
The signal
would,
issues.
Sir?
Your signal is weak, I think.
Can you hear me, sir?
Yes, ma. Yes, ma.
Can you hear me?
Yes, ma. Yes, ma.
Uh,
Proceed.
We'll try to proceed with the definitive repair for this child, sir.
But that is the surgeon who is going to do. What are you going to do?
Yes, sir. We have investigated the child, sir. Which
What
started the
exactly
child
are you going to do?
analysis.
For example, dental prophylaxis, you will advise, dental hygiene, you will advise.
Started,
Similarly, what exactly are you going to do? For
we
this
started on a child on oral propranolol, sir.
Okay.
Child is
But
not anemic.
on oral propranolol, this ECG around 80 is okay, but your clinical examination was 105, which is a little unusual for this propranolol, if it is in the right dose. Okay, doesn't matter. Go on.
We advise the child to have maintain a good hydration, good oral hygiene, sir.
Okay.
Since
About the
child had
vaccination,
dental
anything
caries,
about the
2
vaccination?
tests were not done, sir. After admission, for dental caries, 2 tests were done, sir, under IE prophylaxis, sir.
We have to optimize the hematocrit, sir, to 55%.
Yeah.
If it goes beyond 55%, and then we'll go for
No,
partial
you need not
extension.
go down
No,
to
it's
55.
not 55, doctor. It's basically you look for, you treat the iron deficiency anemia. If it's a symptomatic polycythemia, only then you try to reduce the hematocrit. By what? Here I was trying to tell you the rough hemoglobin you should have based on your saturation. It's 38 minus saturation by 4.
Okay, sir.
So if it's falling beyond 2 or 3 gram percent, the child is going to be anemic. Okay.
Okay, sir.
The rough
Okay, sir.
calculation for the expected hemoglobin for the expected saturation.
Okay, sir.
Okay. For us, let's say 38 minus saturation will be 100 by 4 will be 38 minus 25 by, that's going to be what? 13 gram percent. Okay. So based on your saturation, when your desaturation is too much, you expect a higher hematocrit. So how do you reduce the hematocrit in a case of symptomatic polycythemia?
We'll go for partial exchange transfusion.
Okay. What is the formula?
80 ml per kg.
No, you have a formula based on your hemoglobin. That's
Based
the
on the
patient's
observed
hemoglobin minus the expected hemoglobin by the patient's hemoglobin into the blood volume. Okay, the blood
volume into observed hematocrit minus patient's hematocrit divided by observed hematocrit. Divided by patient's hematocrit.
Yeah, into blood volume.
Into blood volumes.
What is the blood volume for this child?
90 ml, around 80 to 90 ml per kg.
80 to 90 ml, it's going to be for a newborn. 90 ml. For an infant, it's going to be 80 ml. For us, it's going to be 60 to 70 ml. Okay, for this age group, maybe 70 ml to 80 ml per kg. Okay, patient's hemoglobin minus expected hemoglobin will be around 65% divided by patient's hemoglobin into 80
Blood
into
volumes.
weight of the child.
Weight.
That is the volume of blood to be exchanged for what? What do you exchange it for?
With normal saline, sir.
With ideally plasma, albumin. If both are not available, normal saline.
Sir, excuse me, sir.
Okay.
Excuse me,
Ideally
sir.
with your albumin, plasma. If it's not available, with your normal saline.
Okay,
Sir,
sir.
excuse me, sir.
Yes.
Sir, we do have a short lecture presentation by Dr. Santosh Kumar, sir.
Okay, okay. We'll close it then.
Yes, sir. In 2 minutes, sir. We'll close in 2 minutes.
Okay. What are the interventions you have for palliation in TOF?
So now we are doing modified BT shunt, sir.
That is BT shunt,
Others are
surgical. Any other that can be done by the cardiologist in a cath lab?
So if in infancy child has any critical pulmonary stenosis, so we can do PDA stenting, sir.
PDA stenting. Good. Other interventions?
infundibular stenting, sir.
That is RVOT stenting.
Yes.
And if the stenosis is predominantly in the valve, you do a pulmonary valvotomy also. So these are the 3 procedures which can be done in a cath lab as a palliation. And surgically, you do all those shunts. You know about what is a modified Ballock Taussig Glenn, odds.
Yes.
It's all you go read up, water stent. Then your definite repair will be Lilly procedure or the ICR with RVOT patch. Okay. We don't have time. We are not discussing about the management in detail.
Okay, sir.
The sir is going to present now.
Thank you, sir.
Thank you so much, Santosh Kumar sir and Gnana Sambandham sir, and Ramya, Vignesh and Gomati and Sridevi ma'am. Thank you so much. Ramya, have you stopped sharing the screen, ma'am?
Yes, sir.
So next we have a short scholarly lecture by Professor Dr. Santosh Kumar sir. Sir, could you please start sharing your screen, sir?
Is it coming screen?
Yes, sir. Yes, sir. Visible, sir. We can go to the slide mode, sir. Slideshow mode. Yes, sir. Yes, sir. Perfect, sir.
So I thought I'll discuss a little bit about cyanotic spell. And during this case discussion, I got some time to add a few 2-3 slides also, which also I'll be showing. Okay. So this is what exactly is tetralogy of Fallot. This is anatomically not a correct picture, but for you to understand, this is say, for example, this is the left ventricle, this is the aorta going, this is the right ventricle, and there is a VSD. So naturally, most of the blood from left should go to the aorta. But in tetralogy, what happens is the infundibular, developmentally, the infundibular septum is shifted anteriorly and superiorly this way. So much so, this infundibular part or the outflow tract of right ventricle is compressed. So it becomes stenotic. And see, like this. So it encroaches onto this. So much so, one, you get a relative pulmonary stenosis. Second, this aorta is dragged this way. So much so, now the aorta is overriding this defect. So much so, it receives blood both from right ventricle and left ventricle. So this is the embryological abnormality which causes the constellation of 4 findings in tetralogy of Fallot. That is, because it is shifted this way, there is a pulmonary stenosis. Because it is pulling the aorta this way, the aorta overrides this defect. So much so, it receives blood directly from right also, in addition to left. And so, when the right ventricle is contracting, the blood is going this way. So much so, there is no outward thrust of this right ventricle wall into your parasternal area, into your sternum. So you will not have a left parasternal heave. Suppose this VSD is not there, only pulmonary stenosis. Then when the right ventricle is pumping, it will have a force that is going outside into your sternum. So the parasternal area will have a heave. But in tetralogy, what happens is when the right ventricle is contracting, it will not come this way. It will go this way because it is easily going into the aorta. So that is the embryological explanation. This is something that I added during our discussion. Okay, now coming to cyanotic spell, so many names are there that we'll skip. So how does it happen? Increased rate and depth of respiration and increasing cyanosis. The child becomes limp, unconscious, may throw a convulsion, may develop a CVA, and may die. So why these things are happening? That is what I am going to explain, try to explain. The spell, the commonest age group is 2 months to 1 year. Time of the day is morning hours, and duration is a few minutes to maybe up to an hour. Precipitating factors, you awakening, crying, straining at defecation, feeding, unpleasant stimuli like needle prick. So these are all basically because your brain is during sleep, you are not active at all. So the brain is having a reasonable oxygen supply. So when you wake up and start crying, the demand for oxygen immediately goes up, and your respiratory center immediately makes you breathe faster and faster. So this idea came from this finding, that is in the spells are less frequent in high altitude natives, which means their brain is used to lower oxygen concentrations, oxygen saturations. So similarly, if your brain is used to lower oxygen concentration, then oxygen saturations, then your likelihood of spell is less. And that is why immediately after waking up and training or crying, you get a spell. But the same cry in the afternoon will not produce may not produce a spell. Basically because due to activities and all, your brain is now getting used to more and more of unsaturated blood. So much so it will not do a knee-jerk reaction of hyperapnea. If I am not clear, you can raise your hand. Now, the spell need not always correlate with the severity of POF, and frequency decreases after morning hours. That I already discussed. No? This X-ray, my plan was to show that when there is in 25% of tetralogy, you can have a right aortic arch. Right aortic arch you make out by the indentation in the trachea that the aorta makes. But that is not very clear in this, so I got a picture from the net. See it is indenting the trachea. So this is the indication that there is an right aortic arch. See the line. This is the normal one, and when there is a right aortic arch, it indents the trachea from the right side. So that's how we make out. So this is one mistake that usually the students make in exam, because when we ask, they point towards this region of the trachea. No, because aorta cannot reach here. No, so it has got to be here. Okay. Now cyanotic spell. This is exactly what we already said. During sleep, there is a reduced oxygen demand, better SaO2. On waking up, you put up some effort, like in a baby crying. So increased ventilation, increased activity, increased PCO2, decreased SaO2, and the pH and PaO2 comes down. So when you hyperventilate, normally what happens, the SaO2 should increase because more and more of oxygen is going in a normal baby. But in POF, what happens, you hyperventilate, there is an increased, because there is an effort. So there is increased venous return to right ventricle. And this increased return to right ventricle makes right to left shunt more. And so whatever blood that the aorta is getting now is more and more desaturated. So more of PCO2, less of PaO2, and low pH. So this is another mistake that usually these students make. RVOT resistance is high. That is here there is a stenosis, so you cannot pump easily. So there is a lot of pressure building up here, but not here. In the pulmonary artery, very little blood is going in. So there you cannot have high pulmonary resistance in the pulmonary artery. So in exam, the students, the mistake that students make is they say high pulmonary artery resistance. No, the resistance is here in the infundibulum or in the valve region. Once you enter the pulmonary artery, there is hardly any blood, so naturally the resistance will not be high. It's either normal or in fact it could even be low. This high resistance is in the outflow tract. So that is, I'm emphasizing this basically because students are making this mistake, saying that the pulmonary arterial pressure is high. In top, it cannot be, the pulmonary artery pressure cannot be high. What is high is the right ventricular outflow tract pressure, not pulmonary artery. Now the VSD is very large and the aorta is overriding the defect. So as I have shown in the previous slide, both the right ventricle and left ventricle can directly pump to the aorta. Why to the aorta? Because it is more difficult to pump to the pulmonary because there is an obstruction here. So the pressure here and here, left and right ventricle is more or less equal. So much so, you cannot have a murmur of VSD in a case of TOF. The murmur that you are getting in TOF is the flow through this restricted area, not this area where the pressure between these two are almost equal. The systemic vascular resistance is dynamic. So if it is dropping, then the right to left shunt will increase. Suppose systemic vascular resistance, that means suppose it is easier to pump. This is going into the systemic vasculation. This is aorta and going into the system. Suppose the pressure here is less, then what happens? More and more of blood from right ventricle will come here. Less and less will go to pulmonary. So the moment the systemic vascular resistance drops, the shunt from right to left increases and the pulmonary circulation further reduces. So that is the important thing. You should never use a vasodilator drug in case of TOF. No vasodilator drug should be given. Okay, cyanotic spell, what happens? You have hyperpnea, increased venous return to right ventricle with fixed RVOT resistance. It need not always be fixed. The infundibular spasm actually may increase also. So, increased venous return and the RVOT is not allowing the blood to go to the right ventricle. So, what happens? From right ventricle, it goes to the aorta. So, increased right to left shunt, and whatever blood is coming from right is desaturated blood. So, your PCO2 goes up, PO2 comes down, pH comes down. And when pH is coming down or the PCO2 is increased or PO2 is decreased, what will the body do? Body will dilate the vessel because they want more oxygen. So, they want more blood to come. So, they dilate the peripheral vasculature so much so the resistance to systemic flow, that is aortic flow, drops. So much so, more and more of blood from right ventricle goes to left ventricle. So it is a vicious cycle once it starts. So increased activity, increased oxygen requirement. Okay, I think all these things we said. So how can you treat? You can treat by decreasing hyperapnea. How do you decrease? You give a drug that will reduce the respiratory rate or sedate you. The typical one is morphine. Side effect of morphine is bradypnea. Now, what else can you do? You can increase the peripheral resistance. So when the peripheral resistance is, suppose peripheral resistance is increased, that means you just imagine that aorta is tied here. You totally block. Then what will happen? In spite of this resistance, your heart will use extra effort to pump it to the pulmonary. So pulmonary circulation will link. So that is what is exactly happening. So when the peripheral resistance increases, the shunt becomes more towards pulmonary. And that is what we want. So morphine you will give. And what else can you give? Actually, you can give oxygen also, so that the saturation is. And this RVOT resistance, you can increase. How? By squatting. By squatting, what happens? You will kink both the lower limb veins and the artery. So much so, kinking the veins means less return of desaturated blood to the right vein. And kinking artery means you increase the systemic vascular resistance. So it has got a dual benefit. And increase in PCO2, what we can do? We can, or decrease in PO2, we can actually give oxygen. Increase in PCO2 causes a decrease in pH. So you can try bicarbonate to bring up the pH. We'll come to the next. So this is the treatment. For my undergraduate, I teach them this acronym POM. That is position, oxygen, morphine, propranolol. These are the 4 things that undergraduate needs. So in each position, how it acts, we already said, by kinking the vein, kinking the artery, and also by abdominal pressure. So much so the splanchnic blood will go into the heart through the vena cava. And the splanchnic blood is more oxygenated than the lower limb blood. So it is slightly better than better as far as saturation is concerned. And oxygen inhalation. Morphine will reduce your respiratory rate. Morphine will sedate you so that you will cry less. And also, there is a thinking that it may reduce infundibular spasm also. And regarding propranolol, it will bring down the heart rate, because heart rate must come down to reduce oxygen consumption. And as it relaxes the myocardium, even the right ventricular outflow tract also relaxes. So much so, infundibular spasm is getting less. So you get more blood into the pulmonary. So this is for the undergraduate. For postgraduate, you have to give a few more things. One is you can give alpha stimulants for vasoconstriction. Phenylephrine is the one that they mentioned. What we give is, what we actually encounter is a tetralogy of Fallot patient comes with septic shock. So septic shock means your vasculature is totally dilated. So there we use noradrenaline. So that will take care of BP part, and also the problem of decreased pulmonary, because by increasing the vasoconstriction, more of blood will go into the pulmonary. And propranolol, how does it act? Propranolol will beta agonist is a vasodilator, so you block it. So much so there is a unrestricted action of alpha, which is a vasoconstrictor. So that is how propranolol acts. And when pH is low and bicarb is low, the vasculature actually dilates. So we want to correct. So soda bicarb will take care of the pH part. And general anesthesia, again, you relax your everything, including your myocardium. So naturally, your RVOT also relaxes and more blood goes into the pulmonary circulation. And the emergency can procedure as the last. Knee chest position, how does it act? We already said. One is kinking of vessel. Second is intra-abdominal pressure, pushing the splanchnic blood that is relatively better oxygenated than the lower limb blood to the heart. Okay. Morphine, how does it act? It will reduce the hyperpnea and also reduces irritability, crying, and so on, and possibly modifies the RVOT obstruction also. That is a thinking. Propranolol reduces heart rate. RVOT contractility is also reduced. So much so it allows more blood to go into pulmonary circulation and increases systemic venous resistance. Systemic, not venous, vascular resistance. That's what we already said, and we explained how it happens. Because beta stimulation is a vasodilator. So you block the beta. That is how you bring about vasoconstriction. Okay. That's all I have to offer. I think I have finished in 20 minutes. Thank you very much. And thank you, Singaravelu sir and Rajendran sir for the opportunity to present my...
Thank you so much, sir. Sir, we have a question in the chat box. Can we include a condition with a reduced pulmonary blood flow in the diagnosis?
That depends on history that you get. If the history, if it is very typical, then we can definitely give. That also depends on the center in which you are working. In a center where pediatric cardiology is very active, then you will be used to saying this sort of diagnosis. But in a usual center, we straight away go to the diagnosis of cyanotic congenital heart disease, most probably tetralogy of Fallot. We may not include that reduced pulmonary blood flow because that is included in the diagnosis of tetralogy.
Okay, sir. Sir, any salient points that a student should not miss in presenting a case of TOA physiology?
I think the presentation was more or less comprehensive. Only thing is, in a case of cyanosis appearing 2 years or later, we must repeatedly inquire whether you can have or you the child did have anything to pointing towards increased pulmonary blood flow during the infancy and had turn to typical fallow later on. That is one thing. And regarding history, most of the important history, bleed also we must negatively say. There is no history suggestive of bleeds because hypoxia is notorious to produce platelet dysfunction and possibly a low grade DIC also. So you can have bleeds. So that is something that we can include. And then regarding the pulse also, pulse volume also. Usually the pulse volume is normal and also it is normal right and left. That if we can possibly say because suppose a BT shunt was done. Nowadays they do only modified BT means you use a count. So modified BT if it is done. Another thing in history is any history of diarrhea, and because that is something that is be positively asked. Then differential diagnosis they'll be asking. You can just go for that 5 keys. Tetralogy of Fallot, TTA, tricuspid, TAP, truncus and all. And you can add admixture lesion. Admixture lesion is just 3, single atrium, single ventricle, and single major vessel. That is truncus. So then they may be asking about the reasons for delayed cyanosis. X-ray. X-ray, in the X-ray shown in this is not typical of TOF because the base of the heart was quite wide, which is not expected. So maybe the major aortopulmonary collateral is joining in the area of that pulmonary, and that is the one that.
Thank you, sir.
Thank you.
Thank you, sir.
And
So,
also
Jnana
when you have
Sambandham.
treatment, when PGs are asked to tell about the treatment of cyanotic spill, sir has in detail told about the treatment of cyanotic spill. They are also supposed to tell about the prophylaxis for prevention of cyanotic, like beta blocker, treatment of iron deficiency anemia, your interventions like RVOT stenting, PDA stenting, valvotomies, BT shunt, and in a ER, even a cyanotic spell may be managed. One useful thing is a small bolus, 5 to 10 ml bolus is going to increase the it's going to improve the saturations. So a small bolus, 5 to 10 ml, short over a period of 5 to 10 minutes, that is going to improve the saturation and maybe a treatment for cyanotic spell, apart from your routine drugs, morphine, oxygen, beta blockers, etc.
Okay, sir. Thank you, sir. Sridevi ma'am, your comments.
Yeah, I think the PG got a bit nervous, but actually the presentation was good. But certain things she got a bit nervous and she got anxious. But I thank the IAP TNSC for giving us the opportunity to participate in the program and give an opportunity for our PGs to present. Thank you.
Ma'am, Ramya was absolutely fantastic. Tirumurugan sir.
Thank you very much. Another lovely session we had, postgraduate session we had. Thanks both to Dr. Santosh Kumar sir and Dr. Sambandham sir. It was basically absolute dissection of congenital heart disease, cyanotic congenital heart disease, and I'm sure our PGs benefited very much from that. Of course, it's never easy to be on the hot seat, so I'm really glad I'm no longer in that seat actually, but that's not true with our PGs. So thank you very much, Professor Santosh Kumar sir and Professor Sambandham sir.
Thank you, sir.
A lot of things which are being told, some of the things which are being told comes only out of experience, and there are a lot of information which is available here which is not given in any books. So it's really for the benefit of the PGs actually. I hope that they, even those who missed out on the live session, go back and listen to the YouTube. And I honestly believe that we are achieving what we wanted to achieve. Actually, what Dr. Singarola and Dr. Rajendran wanted was something like this, where there is a lot of discussion and also some special inputs from the faculty. So we have achieved it in both the sessions so far, and we are going to have more such blockbuster sessions. We are planning for 12 this year. So thanks to some wonderful participation from everybody. We have had a fantastic. Thank you very much. And Rajan sir, I come for Rajan sir.
Singaravelu sir.
Singaravelu sir.
They are not here, I think.
Okay, I think they're okay. So thank you very much. I think we'll conclude the session. Good night. Good night.
Thank you. Thank you.
Thank you.
Okay, sir. Thank you so much, Santosh Kumar sir, Jnana Sambandham sir, Sridevi ma'am. The presenters, I learned so many intricate details about TOF today. I had got 20 learning points. I think it will be very beneficial to postgraduates also. Thank you so much to everyone here.
What we have started doing is to use the Zoom AI to convert it into, I mean, the whole discussion has been summarized. I haven't had the time to circulate it. Probably I'll send it to Kritika to go through it. Yeah, it gives a very good summary. It's fantastic. I'll mail it to you, so it can be circulated. It's very useful also.
Sure, sir. Sure. Thank you very much. Thank you so much.